To talk on anatomy of interatrial septum and interventricular septum with reference to the intervention. I know.
Nice to see you there. I hope all of you are safe. I spoke to Nagesh day before yesterday as to what he wants from me, because this is an interventional meeting. Even I'm not sure whether this is an appropriate forum in this particular talk, but I decided to concentrate on basically the anatomy of the atrial and ventricular septum, and also the echo pictures of how we classify atrial septal defect and basic ventricular septal defect. It may not be directly related to the interventional aspect of this whole thing, but you have to bear with me. Now, this is something which we are always very scared of, that is the embryology. But as far as atrial septal defect is concerned, you have to remember a very important thing, that it starts with the ostium primum. That is, the ostium primum, the septum primum grows down in the 4th week of the embryological growth. And then subsequently it gets replaced by what is known as the septum secundum, which is actually, if you look at the right side bottom screen, is actually the ingrowth of the atrial wall. This is not a part of the septum. So if you actually look at the anatomy of the atrial septum, the only true fossa ovalis is that portion of the atrial septum which is a part of the septum primum. The rest of it, they are all actually the protrusions of the muscular portions of the atria, which actually start superiorly from here, then goes down and then extends anteriorly towards the aorta and inferiorly towards the inferior vena cava. So the true portion of the atrial septum, as we see, is not the whole septum, but what was originally the septum primum. That is what is known as the fossa ovalis. So this anterior rim, if you see, continues into the aorta here, and then inferiorly that whole muscular portion of the septum then continues towards the IVC. So when we start assessing an atrial septal defect, it is always nice to start with the clinical X-ray, ECG, and also the oxygen saturation, because the evaluation has to be complete. It is only then that we should move on, which for atrial septal defect includes transthoracic echo, transthoracic echo, which is usually a 3D echo, and of course the ICE, which is used for intervention. I will be restricting my talk only to the transthoracic echo, because tomorrow Saurabh is going to speak about transesophageal echo evaluation, etc. Very rarely do we have to use MRI or CT, although there are studies which shows that there is a good correlation of MRI with echocardiography as far as rims size and all is concerned. And of course, you have to be prepared for a cardiac cath. Even if you want to intervene or no intervention by device closures, you have to be mentally prepared for a cardiac catheterization study. So let's look at the anatomy of the type of interatrial communication. This is a cartoon where the anterior wall of the right atrium has been removed. And what you're seeing is the interatrial septum and the various places. Most of you, of course, would be familiar with this, but for a beginner, it might give you some information as to how the atrial communication exists. Actually, the true Fossa Ovalis ASD is actually in the center, and the rest of them, they are all away from what is the embryological atrial septum, which is only the central portion of the atrial septal communication. Echo assessment is the cornerstone for imaging. In many cases, this may be the only investigation necessary for the treatment in terms of anatomy, size, rims, hemodynamics, ventricular function. This echo may be the only thing necessary. Correct assessment of rims is usually necessary when you're contemplating of a device. But when you know, if you look at an echo and see, oh, this is too huge for a device closure, then generally we are not very bothered about trying to measure the rims, etc. And we just go ahead and mention the size and then go on to the hemodynamics, etc., before we contemplate referring to the surgeon, and if necessary, do a cardiac cath. I believe this is very important. Current nomenclature of the rims is absolutely important. It is important to define the rims according to the adjacent structures like SVC, IVC, atrial, AV septal, retroaortic rim. Unfortunately, even in today's echo reports, we frequently ignore these for vague terminologies like superior defect, inferior defect, anterior defect. We still see reports which do not follow the strict criteria of defining the rims, because when they come to you with these reports, they expect you to give you an answer as to whether you would be able to do it by device or whether the patient has to go for surgery. And many times we have to tell them, look, this is not enough for me to conclude. So that's very embarrassing. So one should try to avoid it, try to follow these rules, and try to define the rims according to the structure that you see. We made a plea for this right way back in the 90s, but it's still being ignored. As far as the ASD is concerned, always start with the subxiphoid windows and use the two which complementary views, the sagittal and coronal. Even when you are doing these subxiphoid windows, you have to make dynamic changes in the scan plane to look at the various parts of the septum. Because if you look at these reports, especially echo reports, one actually tends to measure the smallest part of the atrial septal defect. Unfortunately, that is not enough. You have to measure the largest portion of the atrial septal defect in order to say whether it is suitable for a device. And this usually happens when you have these fixed sagittal and coronal views and you don't change the dynamic nature of the scan plane and then miss out on the largest size of the defect and then tell them, oh, this is suitable for a device closure. Also, these views, it will help us to rule out sinus defects like IVC or SVC. But that if the subxiphoid windows are not good, then TE is the only option, especially when you're trying to plan a device closure. Also, it is a very important window if one is considering a device closure without resorting to general anesthesia and TE. So if your subxiphoid windows are not good for evaluating an atrial septal defect, then it is quickly better to move on to the transesophageal VCOs, define the rims properly, define the size properly, and then you may or may not decide to do the device under GA or TE guidance. That's up to the operator, although we believe that almost all the atrial septal defect, even if it looks very good, should be done under general anesthesia and TE guidance. This is especially true for the beginner. As your experience increases, you can choose which ASD to do without general anesthesia or without TE. But as a beginner, I think this is a very, very important thing to do. There is always this excuse, I don't have an anesthetist because I don't have a TE. You should try to take shortcuts. Am I okay? Because it's coming as muted. My voice is muted. Bharat, can you?
No, sir, we can hear you.
Okay.
Just a second, sir.
Sir, please go ahead.
Thank you.
Yeah, and somebody is trying to draw something on the screen.
Yes.
Please don't draw anything on the screen.
So here we have the two complementary coronal view, which looks at the atrial rim, at the AV septal rim, and then we make a measurement here. We then move on to the complementary views, which looks at the SVC rim, the IVC rims, and then we make the measurement. Because remember that these are fixed views. As I said, you have to scan the atrial septum even in these views in a dynamic way, going superiorly, inferiorly. So this should not be forgotten. Otherwise, you will miss the largest size of the defect and tend to concentrate only on the views which looks very good. This is the third view, which is the epic, which measures the IVC rim. It also measures the AV septal rim. And finally, the fourth view is the parasternal short axis view, which looks at the posterior limb, which is actually the pulmonary vein and the So these are usually which makes us decide whether we are able to do it with a device or not. So this is as far as the fossa ovalis is concerned. If any of these images are not good, then I think we should not hesitate to do a TE in order to get a complete information. The other types of defects, all other atrial communication lie outside the confines of the true atrial septal defect, embryologically speaking. So there is a plea not to call them as atrial septal defect, but just to call them defects, although intuitively, because of many years of habit, we still call a sinus venosus ASD, an atrioventricular septal ASD, coronary sinus ASD, etc. But there is a strong plea as to not to call it correctly in terms of embryological defect. There was a time when all these were never considered for a device has coming and which has been going on for quite some time, for the past 2 or 3 years, when people have started closing sinus venosus defects. So it is one day we might start and close the IVC type of sinus venosus defect. We never know. So it is very important to understand the anatomy. So I'll be talking briefly about the sinus venosus defects and the atrioventricular septal defect. SVC type of sinus venosus defect, basically they are defined as an overriding of the superior caval vein with a biatrial communication. So per force, it's a very superior defect. What is always associated is a PAPVC of the right upper pulmonary vein. It is a part and parcel of the defect. Many people don't understand it because they come and ask you, what about the pulmonary veins? Is that also draining anomalously? And these are from people who probably don't understand the anatomy very well. So PAPVC of right upper pulmonary vein is always the part of a superior sinus venosus defect. If a fossa ovalis ASD is also present with it, remember that the criteria for diagnosis is that you have to have a tissue which separates the two. Otherwise, it just becomes a large fossa ovalis ASD which is extended superiorly. So we have to differentiate these two. For a pure SVC type of defect, you have to have a rim which is separating it from the fossa ovalis. These things are very well demonstrated by using the subxiphoid sagittal views. It is completely missed in the 4-chamber views. So if a subxiphoid view is poor, then you should always use the TE if a suspicion of ASD is strong. Let's look at this image. This is an apical 4-chamber view. One could never imagine this patient would have an atrial septal defect. And this has happened. It still happens. What you notice is, of course, the right atrium is enlarged. All you need to do is, if you can get a good subxiphoid image in this particular picture, you know that you're dealing with this SVC type of sinus venosus defect. Many times what happens is the defect is extremely anterior and superior. And you can actually miss it even during a good subxiphoid window. And the example of this is the one which I pointed out in the bottom picture. It has been also known that sometimes even the surgeons can miss it if they are a bit casual about it. I have had instances, twice I have had instances where a patient was chest was opened up with a diagnosis of sinus venosus defect, and the chest was closed and said there was no defect because it was lying so superiorly and anteriorly. But in 99% of cases, the subxiphoid window is good enough to diagnose a superior type of sinus venosus defect. IVC type of sinus venosus defect are much more difficult to diagnose. It is easy to diagnose the defect, but it is difficult to label it as an IVC type of sinus venosus defect. It is very common, if you see the reports coming in, to label it as a fossa ovalis defect. The features like the SVC type of defect is that here it is an inferior and posterior defect. You have the overriding of the IVC instead of the SVC, but it is not easily appreciated. Again, it has to have an intact fossa ovalis. If a fossa ovalis ASD is also present, then there has to be tissue which separates it, very similar to that of the SVC type of defect. And PAPVC of the right lower pulmonary vein is optional, and many times it is difficult to demonstrate. So this is the example of a dynamic scanning, which is very important. It's the same patient. You see in a superior scan where the SVC is entering the right atrium, it looks as if the atrial septum is intact. But the moment you sweep it posteriorly, you see this large defect which is appearing, which is towards the IVC, not yet fully clarified, but then you could have completely missed it if you don't do a dynamic scanning of the atrial septum. The left side screen looks as if it is an intact septum, but the right hand screen clearly shows that there is a large defect which is inferior and posterior. Another example, this is the same patient where you see that the fossa ovalis is intact. Intuitively, you would say that, oh, look, this is an intact atrial septum. Unless you do a posterior scan, you see this huge defect appears and you see that the IVC is overriding this defect. So that's the importance of a dynamic scan in order not to miss these difficult type of atrial septal defect. This is an apical four-chamber view. Typically, in an apical four-chamber view, if you have a SVC type of defect, you don't see the defect in the superior portion of it. But here, you clearly see, because here it is typically at the entrance of the IVC, so you don't miss these IVC type of defect in the four-chamber view if you're looking for it thoroughly. And now it is considered that an IVC type of sinus venosus defect is best seen in the parasternal short axis view, where you see that the defect is more posterior, and you also notice that the PFO is intact. So that is what is the diagnosis. Of course, you would, many of these reports that you would see would diagnose this as a fossa ovalis. Now, regarding the PAPVC, it's a difficult thing to diagnose an IVC type of defect, but these are a series of 4 pictures in the parasternal short axis view and the apical four-chamber view, where you clearly see that the pulmonary vein, typically the right lower pulmonary vein, is actually the defect.
Can you be a little more closer to the system?
Okay, you can see.
Yeah, that's perfect, sir. Perfect.
You can see that the right lower pulmonary vein is actually straddling the defect and causing a partial anomalous pulmonary venous connection. But these are difficult things to diagnose, and TE generally is not very helpful in these situations. Atrioventricular septal defect, we all understand, is a more complex anatomy. We have to use a combination of views in order to assess the defect and the hemodynamics. Typically, we have a common AV valve and a separate AV valve. In the common AV valve, you can have a large ASD and a large VSD, whereas in a separate AV valve, typically you have a large ASD and a restrictive VSD. But remember that you can have the whole permutation combination with various sizes of the ASD and ventricular septal defect. Of course, you have this atrioventricular valve regurgitation, LVOT obstruction, so much more thorough assessment needs to be done. Here is a combination of view. The upper panel shows that this is a partial atrioventricular septal defect. This is a sagittal view from the subxiphoid. You can see a large atrial septal defect in the so-called ostium primum position, but you see that the ventricular septal defect is absent, or it is very small. If you look at this here in the right-hand corner, you don't see a very large ventricular septal defect. Anatomically, it is large, but it has been tethered and it is physiologically closed. Here is an example of a partial atrioventricular septal defect in the bottom left side, and you see that there is a very small atrial septal defect. And you feel, oh, there's nothing needs to be done possibly for this, but suddenly you notice that because of the cleft mitral valve, there is severe atrioventricular regurgitation. So these are things which needs to be clarified. This is a much more complex form of atrial septal defect and which needs thorough investigation. Of course, till now, we don't talk about any interventions in these type of atrial septal defect, but since I had to talk about the anatomy of the atrial septal defect, that's why I wanted to complete this. Here is an example of a complete atrioventricular septal defect, where in the sagittal view, you see a complete common atrioventricular orifice. Here, you notice it in a moving picture, and in the right-hand corner, you notice that there is a very large ASD as well as a large VSD. So you can have these permutation and combination with these type of atrial septal defect. I now move on to the anatomy of ventricular septal defect. There was a time when we all trained, we would always look at the ventricular septal defect from the left ventricular side. We always did a left ventricular angio. We would say that this is a subaortic VSD, utilize all sort of terminologies. We would do a right ventricular angio in a LAO view, left ventricular angio in a LAO view. We would do a left ventricular angio in a REO view. That's all we had to do. But now, the way we look at the ventricular septum is completely different. We actually look at it from the right ventricular aspect of the ventricular septum instead of the left ventricular opposite, which was the traditional view when we trained. So if you look at these images, you see you are opened up the right ventricular portion or anterior wall of the right ventricle, and here you see definitive landmarks. We see the pulmonary valve, we see the tricuspid valve, the septomarginal trabeculation, and it is based on these definitive landmarks, which is not present on the left ventricular aspect, that we start defining where a ventricular septal defect is present. And this is how we define the ventricular septal defect nowadays. We have removed the right ventricular free wall. We are looking at the the right ventricular aspect of the ventricular septum in an en-face view, and we define the various types of defects: the perimembranous defect, the inlet defects, the outlet defects, and the trabecular defect. These are the commonly used terminologies nowadays. Most of you would be familiar with this. Evaluation of ventricular septal defect forms the same schema of evaluation. We have to do the clinical evaluation, X-ray, ECG, etc. Again, echo remains the mainstay of evaluation. Transthoracic echo typically suffices in most of the patients, especially in the pediatric population. So we hardly ever use the transesophageal echo in order to evaluate a ventricular septal defect. Also, the images are never as good as the transthoracic echo in order to define the ventricular septal defect, and typically it is restricted to beyond adolescent or adults. And with this echo, we are able to define the anatomy, we get the hemodynamic information, and when we have to intervene, we also get the other bit of information like margins, the size, whether it is suitable for a device closure, or whether the patient has to go for a surgical treatment. 3D TE is becoming more and more popular in order to define it in a much better way. There have been papers, especially Dr. Shiva has written about the 3D, and actually he follows the same schema as we have following for the defining a ventricular septal defect. He looks at it from the right ventricular aspect and then makes the diagnosis. MRI, which probably will be discussed later, is more often used for complex ventricular septal defect, hardly ever used for intervention, but definitely has a role in evaluation of complex ventricular septal defect in order to look at rootability, etc., as a surgical candidate. And of course, cardiac catheterization is necessary in appropriate cases. But our initial diagnosis is always echo, and I think in the pediatric population, transthoracic echo suffices in most. So let us look at quickly the various type of these defects. Perimembranous, because these are very loosely used terms. Even now, if you look at the echo reports that come in, subaortic VSDs, perimembranous VSDs, they are all a potpourri of terminologies which are used, which has to be clarified. Especially for the beginner in pediatric cardiology, you should make all attempts to clarify the terminologies which we use in defining these ventricular septal defect. So perimembranous VSD, which was loosely known as subaortic VSD, is basically involves a fibrous continuity between the leaflets of the tricuspid, mitral or aortic valve. This is the pathognomonic feature. The septal leaflet forms the postero-inferior margin of the defect, and multiple views are used to differentiate these features. We start with the subxiphoid as also useful, the parasternal long and short axis. And now that we have started doing device closures of many of these defects, there was a time when we were quite happy in saying that this is a large defect, this is a moderate defect, this is a small defect. But now, if you are planning intervention, we have actually got to talk about the size of the ventricular septal defect, what about the margins, etc., and finally give a report whether it is suitable for a device closure. This is a typical example of a perimembranous ventricular septal defect. You can clearly see in the left-hand corner that the postero-inferior margin is formed by the septal leaflet of the tricuspid valve. And for people who have done angiographies in the past, this view is typical of the eleo-cranial view that we use. And you can see how the VSD skirts the septal leaflet of the tricuspid valve and then falls down. So if you're used to angiography, this becomes very difficult, very easy to interpret these types of ventricular septal defect. This is a parasternal short axis view, which clearly shows the leaflets of the non-coronary sinus in continuity with the tricuspid leaflet, which is actually a very important part of the diagnosis or definition of a perimembranous defect. Now, if you look at this, this is a paracoronal view of the subxiphoid view, and it shows so clearly, this yellow arrow points out to the continuity of the tricuspid valve and the aortic valve, therefore defining it as a perimembranous defect. This arrow here points to the fact that the outlet septum is intact, and therefore this is not a doubly committed ventricular septal defect. So these are the ways that we define perimembranous ventricular septal defect. This is a parasternal view with an inferior tilt, and you can clearly see how the tricuspid valve is very closely related with the non-coronary aortic valve leaflet with the ventricular septal defect. So that, I think, completes the definition of a perimembranous VSD. A doubly committed VSD is a very, very superior defect, which you saw in the cartoon there. And you can clearly see that now in the subxiphoid view, the pulmonary valve actually forms the roof of the defect. Also, you notice that the jet is going towards the pulmonary valve, and you don't see the tricuspid valve at all in this particular view because it is far away from this, and the jet actually points towards the pulmonary valve. It is happening now less frequently, but there was a time when many of these patients used to be diagnosed as severe valvular pulmonary stenosis. But fortunately, with the new group of pediatric cardiologists who are now actually practicing, these things are seen less frequently, unlike before when the adult cardiologists used to report these echo. Here is a subxiphoid view, which is a restrictive ventricular septal defect, which you can clearly see here that the tricuspid valve and the aortic valve are continuous with each other in this yellow arrow. And in this arrow where you see that the pulmonary valve and the aortic valve are continuous. This is a parasternal long axis view, which is the best view to define the aortomitral continuity, the aortopulmonary continuity, and you can see how very well the VSD is seen. This is very important because we don't think that this is suitable for a device closure, although I'm aware that there have been attempts to close these small ventricular septal defect with a device, but intuitively it seems very wrong because there you have the aortic valve and pulmonary valve right forming the roof of the defect, and therefore it should not be attempted. Another example of a doubly committed in the short axis view, where you clearly see how the tricuspid valve is discontinuous with the aortic valve and how the aortic valve is continuous with the pulmonary valve. We then move on to the muscular ventricular septal defects. These are very important because many of them are now attempted with device closures. You have to understand the anatomy very well. Remember that they are far away from the tricuspid valve, unlike the perimembranous ventricular septal defect, but sometimes it so-called hides the ventricular septal defect. If you look at this particular image, the tricuspid valve actually has got to be separated in order to show us the ventricular septal defect. And one has to be very careful as far as device closures are concerned in order not to damage the tricuspid valve during this procedure. So understanding the anatomy becomes extremely important. This is a so-called a muscular inlet type of ventricular septal defect, which is so closely related to the tricuspid valve. So one has to be very careful in doing an intervention. This is an inlet type of ventricular septal defect. You can see that there is an absence of offsetting here. One is the apical four-chamber view, the other is a parasternal short axis view. Clearly, one does not talk about device closures in these type of ventricular septal defect because there is no margin in the AV septal area. So the importance of defining these very clearly. This is a very anterior type of muscular ventricular septal defect. You can see it only in the superior scan when you see the right ventricular outflow tract. And you can see the ventricular septal defect. It has got margins all around, muscular margins all around. If necessary, of course, this is a very small ventricular septal defect, but if necessary, they can be attempted and a device closure can be done for these type of ventricular septal defect. This is a typical, what we know as the apico-infundibular ventricular septal defect, which was initially defined when KK was working in Boston. The purpose of just to show you is that not all apical ventricular septal defect are simple. You can see that you see it only when you do an anterior scan pointing towards the right ventricular outflow tract. And of course, many of these patients are only surgical candidates. It is difficult to attempt and try to close these ventricular septal defect because these are true apical ventricular septal defect with hardly any margin towards the apex. But it is just a matter of interest that I am showing you this defect. Most of them actually are large and they tend to go for a surgical correction. I think I'll stop my talk here and just appreciate if there are any questions or comments on.
Really, it's really wonderful and a very lucid talk, sir. A lot of information. And you are the first person to do nomenclature of the interatrial septum. Many of the people, they don't know actually the nomenclature came from you and Savitri Srivastava madam, published a long time back actually. Still all over the world, people follow same nomenclature. And the last slide is very, very good what you mentioned, because ourselves, we attempted in 2 cases to do the device closure in apico-infundibular VSD. Wonderful publication by KK and Jim Locke's group from Boston. After that, one of my colleagues also, we reviewed the paper and then we understood the anatomy very clearly, which you are showing today. So I request others, Dalvi sir or whoever is available to discuss certain issues. And also Dr. KK requested me to invite Dr. Babar Hassan, Chief of Aga Khan. Is he there? Sir, are you there? Satya, can you please invite Dr. Babar Hassan?
Yes, sir. I'm unmuting him.
Can you guys hear me?
Yeah, we can hear you, but we can't see you. Can you open your video?
Yes, I can open it. Let me see if I can open that.
Yeah, I've just sent a request. Right.
Yeah, okay. My internet probably is not that good, so probably it may not open that well. So anyhow, but this was an amazing session. Really learned quite a bit. All 3 talks, and really wanted to really thank you guys to do this. One could not have imagined, sitting completely in different parts of the world and listening to this and learning so much from so much of extreme experiences, and all talks. KK is I give his I have his talk with me, and I give it to all of our junior faculty and our fellows and everybody, because everybody, as KK very rightly pointed out, it's all that excitement of putting a device in and not understanding the whole logistics behind it. But also along with that, Dr. Dhelvi's talk, I think we completely underestimate the whole concept of counseling. Such humility in that talk was truly amazing. And the ASD, it was music to my ears as I kept on writing, because I kept, we always get into these, I know it's more of an intellectual academic arguments, but, only when one is meticulous about such things, of defining things and actually defining it properly, is when we understand that it shows our understanding of the defect. And that, I think, counts a huge deal when you are in the cath lab or in surgery. So thank you very much for this amazing sessions.
Thank you very much, sir, your valuable comments. Are there questions to Radha sir? Dhalvi sir, would you like to ask any questions or comment of Radha sir's talk? You please unmute your microphone.
Sir, I've done that.
You have to unmute. We can't listen you. We can't hear you.
I know. I have now
unmuted. Yeah, I've done it.
Yeah, I think just wanted to emphasize what Radha said, that how imaging is at the heart of interventions. Many of us tend to think that pushing catheters and pushing devices is the way to go. But I think imaging is at the heart of successful interventions, and is also improper imaging is at the heart of complications. So unless you are satisfied with the kind of images that you have, I think going ahead with any form of intervention, may it be transcatheter or surgical, I think can produce really some disasters. And some of the images which Radha showed are, I have been seeing them for years, just terrific. Thanks for sharing your experience, Radha.
Yeah, Dr. Babar would like to ask a question. You can please go ahead.
Sorry, I missed out. While Bharat was speaking, there was some instability in the internet. Can you start your question again, if it is addressed to me?
Satya, can you ask Dr. Babar to speak? Satya, can you unmute?
Yes. Yeah. He's already unmuted. 1 minute. And there are some more questions, sir, which I've sent you on the WhatsApp. These are to all the speakers. So if you have time, if you can address it. Dr. Babar is unmuted.
Dr. Babar, can you please ask a question, or else your internet may be a little bit poor connection. You can type the question also if you're not audible. Okay, then Radha sir, did you get your questions? Yeah, I can't unmute, he said, but you can type your question. At least we'll repeat your question.
I have some questions with me here.
So I can unmute. Can I quickly go through? So just if everybody who gave a talk can give a little bit of the modification that they are doing with the whole COVID-19. So for KK, are you now using a corona or COVID test before you take a patient to the cath lab? For the imaging folks, are you now really discouraging any kind of sedation TEE because it makes the patient cough a lot, and all TEEs done under GA?
To answer that question, KK had to go some kind of urgent work, so he is not available at this point of time to answer. But I had the interaction couple of days back with the KK. They are not doing any kind of elective interventional procedures as of now. Only emergencies, he said, and they are using all precautions of personal protection equipment. Maybe you can ask personally, you can
same here, Nagesh, we have stopped doing elective procedures for now.
Yeah, others can answer. Even Bharadali sir can answer that question.
No, we have also stopped doing. As a matter of fact, for us, there are hardly any patients, and our hospital policies are very strict in this aspect, that no elective patients will be done.
Radha sir, you have some questions in your WhatsApp. Can you see and then speak? We have a couple of minutes of time.
I couldn't
We
get
can
it.
stop after 5 minutes.
Yeah, closing trabecular VSD in patients with non-obstructive RVOT muscle, can this delay the progression of the obstruction? The answer is no. I mean, it's a separate pathology. I don't think closing would help. The difference is that the VSDs tend over a period of time to get smaller, but the RVOT obstruction always almost progresses. That's what the natural history explains it. So if you feel that there is an RVOT muscle, and if the VSD is not big, it can wait. I think it is better to wait and let the natural history unfold by itself over a period of time if the patient is not symptomatic. If he's symptomatic and you feel that it is because of the VSD, then of course it is better to send it for surgery.
I'm actually able to come back now to the meeting, Nageshwar. So,
there are some questions from Dr. Babar, but I can repeat whether his microphone is mute or unmute. I don't know.
I heard that discussion and you answered for me. That's fine. That's exactly what I would have said. Now,
do you know his question?
Yes, regarding COVID patients, what you need to do, what precautions you need to take. He said that we've stopped elective procedures, and for emergency procedures, we wear personal protective equipment. That's exactly what we are doing. Right now, we haven't actually reached a stage where we have declared community transmission. So our current situation in Kerala is that we don't assume everybody is COVID positive yet. So we follow PPE only if there is a suspected COVID or a proven COVID case. Otherwise, we are not having to wear PPE for other cases as such. This universal COVID precaution policy will only come in when there is an official declaration of community transmission. That hasn't happened yet. So we need not, it's extremely difficult to function in PPE for anything. To do interventions is very, very difficult. So one has to be really absolutely sure if it is, firstly, the procedure is indicated, and secondly, you can, if you can actually avoid doing it for that particular period of time, that may be the most appropriate thing.
There is another question here, timing of device closures for VSR. I mean, you mean ventricular septal rupture?
Yes.
Well, it's a very controversial issue because there is something called damned if you do and damned if you don't do. You know, ventricular septal rupture, if you look at the recommendations of European Society of Cardiology and American Heart, they don't even talk about device closures. Today, the best option is to do a surgical closure. They have been able to bring down the mortality of surgical closures of ventricular septal rupture down up to 40%, unless it's a desperate situation. And typically, it's a question of saying, coming back from the cath lab and saying that, oh, my procedure is successful, but the patient is not alive. Because remember that there are multiple issues in these. If you have ever gone to the operation theater and looked at a ventricular septal rupture and seen a jelly-like structure there, you always wonder how you can fix a device here. Although there have been reports of successful device closures, but the success typically occurs in patients who can tide over about 4 to 6 weeks period so that the margins are firmed up and you can easily fix a device if it is necessary. Typically, these occurs in patients who do not have very large VSDs, they have not gone into cardiogenic shock, etc. There is a second group of patients who come to you after surgical closures of ventricular septal defect because they face the same problem. The tissues give away. They come back to you with a residual shunt, typically after some time, after 4 to 6 weeks. These are patients who are probably suited for device closures. I used to do ventricular septal ruptures in the beginning, but then I realized that I don't think we should do it in the immediate period. It is better to send the patient for a surgical closure.
Screen sharing so that I can show tomorrow's question.
Nageshwar, there are a few questions for me. Do you want me to take it now or shall I?
Yeah, so we have 3 more minutes time. One question each can be answered. At 1:30, we would like to wind up this session.
Okay, I have one question I'll answer quickly. That is warm saline. It's very easy. You just take the bottle of normal saline and put it in a warm water bath. And you can get it up to, you can put a thermometer if necessary, but that's also not necessary. You can get it up to a reasonably warm temperature, and then that warm bottle can be used for the babies, and it's very essential for the very tiny babies.
Thank you, Nageshwar. That was a wonderfully conducted session. Nice to see KK, Bharat, everyone, and very happy they're all very safe.